Good afternoon to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Murkan Shankaranathan. Sir is senior consultant in HIV and sexual medicine at Tamil Nadu. Sir is a former national president of Indian Association for the Study of Sexual Transmitted Diseases and AIDS. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is cracking the management challenges, unusual presentation of opportunistic infection in HIV. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Good afternoon, everybody. At the outset, I thank the moderator and Mentox for giving me this opportunity and for her kind introduction. Today, I am going to talk about two interesting case reports in HIV disease, especially related to sexually transmitted disease. In our country, those who are handling HIV diseases are very few, not all. It will be definitely interesting to the people who are already handling HIV care. For others, it may not be so informative or interesting. If they are already handling HIV disease, definitely it will be interesting. Let us go to the case presentation. So, Granuloma inguinale. So, one of the STIs, sexually transmitted infection. It is actually it is one of the olden diseases. When the STD or STI being called as venereal diseases, this was also included. But of recently, number of cases have been reduced, occurs sporadically then and there. So because of that, even Center Disease Control, that is America, US, and also NACO, National AIDS Control Program, everybody not giving adequate importance to this disease. But we do get cases occasionally, about which the interesting point I'm going to point out. It's a tropical sexually transmitted infection. It is it is uncommon in subtropics, mostly common in tropical. It was previously, especially in India, we do get cases when we were postgraduates, undergraduate, but nowadays very rarely it comes. Though it is rare, reported sporadically all over in our country, then and there. Reports are coming, but in spite of that, the guidelines are missing. Earlier, it was more prevalent among the Coromandel coast. Coromandel coast means Tamil Nadu, Andhra Pradesh, Orissa. In there, those area, it is more common rather than other part. But I have come across recently cases from Madhya Pradesh also. Because of its rarity, NACO guidelines simply omitted this disease. Like any other anogenital ulcers, it can facilitate the transmission of HIV infection. Any ulcer, any inflammation in the genital area facilitates the transmission of HIV infection. Likewise, this also can facilitate the transmission of HIV infection. Unlike other STIs, the conjugal and vertical transmission are very, very minimal. Whereas in syphilis, whereas in chancroid, whereas in gonococcal infection, conjugal and vertical transmission are quite common. Whereas here it is not so. Management guidelines as per Centers for Disease Control, United States, azithromycin 1 gram orally once a week or 500 milligram daily for 3 weeks. We have to give until either 3 weeks or until complete healing occurs. Alternate regimen, it is indicated as doxycycline 100 mg orally 2 times a day for at least 3 weeks or until all the lesions have completely healed. Or erythromycin base 500 mg orally 4 times a day for 3 weeks or until complete healing. Another drug also indicated, that is trimethoprim sulfamethoxazole, double strength, twice daily for once again 3 weeks or till complete healing occurs. So these are the drugs recommended for the management of granuloma inguinale. HIV and granuloma inguinale. The course of any disease is opportunistic infection, whether it's tuberculosis, whether it is syphilis, whether it is herpes, definitely altered by the presence of HIV because of low immunity. But the CDC guidelines recommend the same line of treatment for the people who are having HIV and also for the people who are not having the HIV. So this is another important thing I want to point out, and how it came as a problem we'll discuss. Here comes a problem. Herewith, I am reporting a resistant case of granuloma inguinale to the recommended line of treatment. So that is the management challenge. Case report. A 60-year-old male, a known PLHV, already on ART for more than 20 years in government ART center. The patient was on the fixed drug regimen of dolutegravir, tenofovir and lamivudine, a combination at present. And he came with a complaint of painless groin ulcer for the past 20 days. He had premarital exposures 32 years back, by which he occurred HIV. His last marital contact, protected contact, is 6 years back. His wife is non-reactive for HIV. And he denied any other recent exposure, any contact, either with men or women. He gave history of recurrent episodes of genital herpes since 1994 onwards, with annual interval of and biannual, sometimes annual interval, biannual, once in a year or twice in a year, it used to recur. Initially, he used to take tablet acyclovir 400 mg 3 times daily. Then it was reported, it was responded only with 800 mg twice daily. Of recently, he used to take 800 mg 3 times daily, then only it was responded. So naturally, in the presence of HIV, all abnormalities can occur. So this history already given. So if with that history, without any recent exposure, one will think of the possibility of a herpetic ulcer. In the presence of HIV, the herpetic ulcer may behave differently with a large ulcer, single ulcer coalesced together. So this can be normal. But at the same time, the patient is he tried acyclovir also. He was having this ulcer 20 days. On examination, I happened to notice 3 bright reddish raised granulomatous ulcer over the scrotocoral folds on the right groin. These ulcers were raised from the surface, not indurated, and varying in size, ranging from 2 to 6 centimeters, and were painless. Inguinal nodes were not palpable. So these are the findings we have to note. And The ulcers were brightly reddish in color. The smear for the giant epithelial cells, that is Zank's test, which is normally done for to prove herpes simplex infection. Negative in this case. Sometimes it may be lab error also, we thought. Whereas in the Leishman stain, we found Donovan bodies, that is characteristic for Granuloma inguinale, Calamytobacterium, found in this crushed tissue smears in the Leishman stain. His HIV viral load was on July 2024 undetectable and his CD4 count above 500 and he was non-reactive for syphilis. He was tried with ofloxacin, cefixime and amoxiclav etc. Before he came to me outside some practitioners. Biopsy from the periphery of the lesion ruled out tuberculosis and malignancy. Confirmed as a chronic granulomatous condition with ulcers lined with stratified squamous epithelium. Now we can see visualize the ulcers. So this was the picture. Scrotum. So it's a thigh region. So we can get nearly 3 ulcers raised from the surface, granulomatous ulcer. So this was the picture seen by me 7 days after the ulcer. I seen first. As I said, I already mentioned, in the Leishman stain, we can see these organisms in the large mononuclear cells. So this is the Donovan body, Calamytobacterium calamities. Now let us enumerate the challenges. I put him on capsule doxycycline 100 mg twice daily, along with tablet azithromycin. I don't want to take a chance. 500 mg once daily, and also tablet acyclovir 400 mg thrice daily, because of the history given by the patient, possibly mixed infection. Like that, I initially thought 2 ulcers were healing and another subsiding, but new painful beefy red ulcers were appearing over the skin of the scrotum on the right side. Patient was having, now it is painful. Previously it was not painful. Patient was having difficulty in walking. So I started him on injection streptomycin 7.75 milligram, 0.75 gram, sorry, and twice daily as per olden dictum. It is not recommended CDC. It is not recommended nowadays. But we used to give when we were postgraduate streptomycin and we encountered very good results. So because of that, I tried. After 10 days, the patient developed severe vertigo. Naturally, one can expect for streptomycin. Without much improvement. Improvement also is not marked over the lesion. And put him on off vial twice daily. So because of vertigo, I made it cut short off vial, that is around 3.75 grams, 0.34. So this is the dose I gave for another 10 days. Then once again patient was, and then the vertigo was persistent, so I have to force to stop the injection streptomycin. Then once again the patient was put on capsule doxycycline as per the guidelines. Why should I take risk? Twice daily, along with the tablet cotrimoxazole, that is Septran. That's also another recommendation, the guidelines, twice daily, double strength. There was no marked response for this treatment also. Then I Even the patient complained of pain, difficulty in walking, and vertigo persistent. And the doxy also stopped, and newer lesions are occurring. Then I put him on chloramphenicol. That's also another treatment, 500 milligram 4 times daily, olden days treatment. But I'm not able to continue without fear because it is likely to go for bone marrow toxicity, blood dyscariasis. So that's also stopped. So we can see this is the 15th day I'm seeing new ulcers. These ulcers were not there. Some ulcers little showing signs of healing, whereas these ulcers spreading. And this is 21st day, old ulcers healed, new ulcers are markedly active. So chlorophenicol also is stopped. His HIV viral load and CD4 count repeated. I doubt he should have marked immune suppression. Because of that, I'm facing all sorts of problem. So repeated after 45 days. It came, viral load came as undetected and CD4 count more than 825. So he is responding to ART well. His immune condition is improving well. In spite of that, this granuloma inguinale gives me challenge. Then the patient was put on tablet cotrimoxazole DS tablets in the dose of thrice daily. Instead of twice daily, I gave thrice daily along with tablet moxifloxacin 400 milligram once daily for another 15 days. Now the patient observes good healing after the moxifloxacin, which is not included in the guidelines at all. Nobody have tried so far. Complete healing was achieved after 75 days of treatment with the moxifloxacin and cotrimoxazole combination. So this is the very important point I wanted to point it out. Nobody has tried, nobody has mentioned, but the patient was responding to moxifloxacin very nicely. Now we can see this is 50th day. This is 75 day, almost healed. Only the pigmentation, hyperpigmentation, depigmentation was there. So you can see, so with the moxifloxacin and cotrimoxazole. So this is the thing. We do get cases of granuloma inguinale. It may be if it is along with the HIV. I have some other references also. Previous two granuloma inguinale cases were reported in Indian Journal of Sexually Transmitted Diseases along with HIV. There also the authors point out delay in healing. One case 12 weeks, another case 6 weeks. Whereas it was pointed out in CDC 3 weeks or little more. But here you can see 6 weeks and 12 weeks. My case, it is 75 days. The CDC guidelines recommends the same treatment to granuloma inguinale for the people living with HIV also, same treatment. In this case, complete healing occurred only after 75 days. That too, not with the drugs recommended by CDC guidelines. CDC means Centers for Disease Guidelines. And so that it is high time to revise treatment guidelines and special recommendations are needed for the treatment of granuloma inguinale is concerned, especially in the presence of HIV infection. In this case, the patient had extramarital contacts. This is another important point. Normally, granuloma inguinale, the incubation period is 2 weeks to 2 months. So that is was recorded in our textbook and previous monographs. Whereas here, this patient have exposure 32 years back and his marital protected exposure 6 years back. No recent exposure he denied. History seems to be reliable. He is already on ART. He is a 62-year man and he is not very competent for sexual promiscuity. So this is another thing. Gets react. So is it possible A older infection, subclinical infection gets reactivated, a latent infection gets reactivated in the presence of HIV even if there is no immune suppression. So that is my point. Sometimes it happens with mycobacterial infection. A old infection reactivated in the presence of HIV. CME infection, usually not manifested. Many people come across, not manifested, but manifest in the presence of HIV. Toxoplasmosis, like that. So, latent infections, presence of infection without any symptoms, has been described in syphilis. Reactivation of tuberculosis, CMV, herpes zoster can occur like that. Herpes simplex recurrence is there. So all these things are there. Likewise in granuloma inguinale also, whether it is possible. So this is another thing we have to think of. Nobody has been pointed out this thing. So this is also I want to highlight. So these are conclusion. Granuloma inguinale still reported sporadically across the world then and there. Moreover, gross underdiagnosed and underreported. After the promotion of syndrome-based management, especially after the syndrome-based management, it is underreported, undertreated, neglected, recognized, under-recognized. These drugs, the drugs recommended for CDC guidelines, have to be revised, especially in the presence of HIV. Moreover, special consideration is necessary for granuloma, that is I told. Reactivation of latent syphilis and granuloma and also has to be considered in the presence of HIV. These are the things I wanted to point out regarding my first case. Next, we will go for. So these are my references. And second case, Candidal periodontitis in a people living with HIV. This is also another interesting case. Candidiasis in HIV infection. So such a common thing. Most of the case diagnosed by the presence of candidiasis, early manifestation. Oral thrush in HIV is one of the commonest manifestation in HIV infection. Sometimes it may be a presenting feature. Candidal esophagitis is an opportunistic manifestation in advanced condition. Oral thrush is early manifestation. Esophagitis is an advanced condition presenting with the odinophagia. Late presenters and dropouts from the treatment often came with esophageal candidiasis. Candidal vulvogenitis in the human, ballopasthitis men is also not uncommon in the presence of HIV. So this candidiasis is not is a common thing. Anybody we can expect. Oral involvement of the candida infection, oral thrush involved in the buccal mucosa, tongue, angle of the mouth, lips, palate can occur. We used to see many. HIV infection is known to for immune condition and it may produce once again esophagitis, oral thrush and esophagitis. I told already. But gingivitis and teeth involvement in HIV are not common. One or two reports I was able to find, but not reported very much. They used to talk about the buccal mucosa, candida, angular stomatitis, cheilitis, everything. Periodontitis means the inflammation of the surrounding structures of the tooth, supporting structures of the tooth. That is called as periodontitis. How here it comes? Periodontitis means inflammation of the supporting structures of the tooth. Bacteria and other microorganisms stick to the surface of the tooth and in the pockets of the tooth cavity or in between tooth may produce all these things. In gingivitis, the gums are reddish inflamed. There will be bleeding during brushing. The teeth are also, they are not loose, not necessarily to be loose. There is no irreversible damage, bone and surrounding tissue. Candle periodontitis is also described, but not much in HIV positive individual, even by the dentist. Candida species detection in the presence of chronic periodontitis, a systemic review has been reported as per this reference. Now the case report. So this patient also above 60, 65-year-old man referred to me with HIV reactive serology. Patient was seen by a gastroenterologist for the complaints of dysphagia, odinophagia, and difficulty in swallowing for the past 2 months. Treated with the drugs he tried without much improvement. He was separated from his wife for 25 years and he lost his child also. So he is living alone. His relatives are elsewhere. Because of all situations, he is an alcoholic also. He had multiple sex partners during these years. As per his words, his last sexual activity is 10 years back, 65-year man. He was separated from his wife for 25 years. I told already, that is the thing. And he was living alone, had multiple sex partners. He had loss of weight and few spells of fever. There was no history of loose stools or pulmonary symptoms. Fever and loose stools. Fever is present and loss of weight, not loose stools. On examination, he was found to have oral thrush over buccal mucosa, tongue and palate. Apart from these are the points. Apart from this, his oral thrush, he was having, apart from his oral thrush, he was having a few teeth. He was having not much of teeth. We can count more than 5 or 6 teeth were there. And the left lower molar and the right upper molar teeth were covered with a white spongy crown and looks odd and bulky, like a bulky crown like thing, spongy like that. He was also having pain and tenderness over the lower jaw on the left side with submandibular lymph node palpable, tender lymph node palpable. So it is covered with a spongy tissue, white tissue, and he was having pain over the lower jaw and tender lymphadenitis, submandibular lymphadenitis was there. So these are the findings. I have seen a lot of cases with oral thrush, pharyngitis, even candidiasis, and anglostomatitis. But this patient having a spongy cover over the teeth and also swelling, tenderness, and with the submaxillary lymph node, submental lymph nodes. He admitted to have loss of weight and few spells of fever. There was no history of loose stools. I told already pulmonary symptom. On examination, he was found to have oral thrush, and apart from this oral thrush, he was having few teeth only. All these things I don't want to repeat. And his CD4 count was viral load was more than 430, 43 lakhs, more than 43 lakhs copies. And his CD4 count was just 61 cell. Normal CD4 count is anything range from 700 to 1100. If it is going less than 400, the patient may have symptoms. So here the patient is having just 61 cells per cubic millimeter. CD4 percentage should be above 25 or 30%. Here it is just 7.5%. The ratio of CD4 CD8 is 0.12. It must be more than 0.5. So the material from the bulky lower molar tooth I told already, that is spongy cover. I took it and scraped with the dry smear and also wet smear, both in KOH preparation and also gram stain. Both were revealing gram-positive fungal filaments. Gram-positive fungal filaments. And the lab report also gives the patient is having candidiasis. So here it is not in the here. This I can see. I was able to see the spongy cover of that, and the patient was having cheilitis and other things. And I can see if it is enlarged, you can see fungal filaments, gram-positive fungal filaments. Gram-positive fungal filaments, Candida albicans. So, after came to me, I put him on oral fluconazole therapy, 200 milligram daily. Normally, 150 milligram weekly once or weekly twice we used to give, normal person. Here the patient, we put on 200 milligram daily basis. A definite improvement was well appreciated within 7 days of fluconazole therapy. ART started with tenofovir, lamivudine and dolutegravir combination, a fixed dose therapy. After receipt of HIV viral report, after the viral report came, I started him. 1 week after the fluconazole therapy, there was no spongy cover. I was not able to see. It is completely all right. Even oral thrush, and he was able to swallow. Stomatitis and cheilitis due to candida are well established entities in early symptoms as the early symptoms, and candida HIV infection, early symptoms of HIV infection, and CD4 lymphocyte count when the CD4 lymphocyte count fallen below 350 or 400 cell, oral thrush can occur. Esophageal candidiasis and esophagitis is also well-known entity opportunistic infection, especially in advanced disease when the CD4 count goes below 200 or 100. So this is the commonest presentation. But periodontitis or teeth involvement in HIV infection was not reported much. Cases of Candidal periodontitis has been reported in non-HIV patients, not in HIV patients who are on steroids, who are on immunosuppressive drugs. When the candida can occur, cause stomatitis, cheilitis, esophagitis in a patient HIV with HIV. When there is no, if there is a possibility of candida can affect the gums also, we cannot rule out. And periodontitis can occur. So this was the thing I want to point out. Not told, not dealt in most of the textbook. So one has to look for involvement of the gums also when they are suspect a HIV infection. So this is the inference I want to give. So you have to search for periodontitis, gum infection also. So this is the take home message from me. Oral manifestation in HIV infection itself, a wide subject in which periodontitis is also to be included and to be looked for HIV patients suspected, diagnosed always. With that conclusion, I thank one and all. These were my references, and I thank one and all for patient listening in this drowsy afternoon. Once again, thank you very much for having listened to me.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Okay.
So, sir, the first question is, uh, what are some key diagnostic challenges faced when identifying unusual opportunist infection in HIV patients?
Diagnostic changes, yes, definitely. Question. There is a patient. We must know what is window period. Window period for there is a test for HIV or antibody test, antigen test are there. Usually antibody tests are we used to do because it is more cheaper, more quicker, more easier, available else everywhere. So it will take nearly more recent tests are up to after 4 weeks it will be confirmative, and older tests are up to 90 days it will be the window period is there. Suppose if the patient comes to you within a week's time of exposure, and if you do HIV test, if it came non-reactive, we cannot confirm. So we have to repeat the test after 90 days. If it is negative after 90 days, you can rule out. Otherwise, we have to repeat. So antigen test, that is PCR, RNA PCR, DNA PCR, may be reactive within 1 week, but it is more confirmative within a month, 3 to 4 weeks. So we can confirm. So this is very important. There are different tests are available, fourth generation tests, and very different tests are available, and confirmation test, Western blot is available. And one more thing is, with single test, we should not confirm the patient is HIV. Sometimes it may be false positive or some other thing. You may be question the court. So what NACO is guidelining, we have to do 3 different types of tests, and if the 2 tests are positive, you can declare the patient is HIV reactive, or with the help of Western blot, we can declare the patient is reactive. But in my practice, all the patients are not able to do all the 3 tests. So I used to do, when there is a typical history, typical clinical presentation, a single test will clinch the diagnosis, and I will confirm with the antigen test, viral load test, to start the treatment. So this is my regimen, diagnostic.
So the next question is, what strategies are recommended for early detection and prevention of uncommon opportunist infection in HIV positive individuals?
Not able to follow. Can you focus the question? Is it possible?
Sure. So the
Yeah.
question is like
Yeah,
this:
bro.
what strategies are recommended for early detection and prevention of uncommon opportunist infection in HIV positive individual?
Normally, previously, we used to start the treatment when the CD4 count goes below 200, 250, 300, 350, sorry, 500. Now, the regimen is start the treatment as soon as possible, diagnose the HIV. In the presence of opportunistic infection, sometimes the patient may be sick or some other problem will be there. So make the patient on treatment for opportunistic infection. If he stabilizes within 1 week or 2 weeks, then we can start the treatment of ART, anti-retroviral drugs for HIV. So that is a good thing, especially in the presence of TB or some other diseases. We have to attend the opportunistic infection first, specific, and diagnose the opportunistic infection and start the treatment for opportunistic infection. After stabilizing within 1 week or 2 weeks, we can start the ART.
So there's one last question. So the question is, how does the management approach differ between common and rare opportunist infection in HIV patient?
No, nothing. We have to treat the same way. At the same time, we have to specific treatment. We have to give specific treatment for the particular opportunity infection. ART is not differing. Now, the present regimen, first line ART contains integrase inhibitor, dolutegravir. It's a less resistant, powerful, and good immune recovery. So the same treatment we have to start immediately of the opportunistic infection. Opportunistic infection we have to treat accordingly as per the diagnosis of opportunistic present infection, and HIV treatment is not varying as per the opportunistic infection. Yes, sometimes what happens, for example, tuberculosis treatment, we used to give rifampicin, pyrazinamide, ethambutol, INH. Sometimes the drug interaction may likely to occur. So in that case, rifampicin may not be adequately enough when along with the ART. So in that case, what they are advising, double dose of ART integrase inhibitor, dolutegravir. So some modification, but same drug, some dose adjustment sometimes may be necessary according to the drug interaction. That is the thing. Otherwise, nothing.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. So, sir, before concluding, any take-home message from your end?
What, madam?
So, I'm asking if there is any take-home message from your end.
Yes. So you have to suspect when the patient is having thin oral thrush and persistent fever or loose stools. Could it be possibly because of HIV? You have to treat the fever for prolonged fever for days together, months together, repeated diarrhea. So in these cases, suspect HIV and check for HIV. Sometimes it may be positive, and unless you are treating control the HIV, you cannot overcome the opportunistic infection. This is the message I want to give.
Thank you so much, sir, for joining us today. And thank you for this wonderful session. It's our
Okay.
pleasure to have you here, sir. Thank you for joining us.
Okay, Sriyan. Thank you very much.